Welcome to the EndoKids podcast, the podcast where we help families navigate the ups and downs and in-betweens of growing up healthy. I'm Dr. Rinku Mehra, the founder of EndoKids Concierge and a pediatric endocrinologist, and my co-host is Dr. Lindsay Waldman, who is also a board-certified pediatric endocrinologist. We are here to break down the science of hormones, share real stories, and answer the questions parents wonder about the most. So whether you're worried about growth, puberty, thyroid, or just want to understand your child's development a little bit better, you're in the right place. We believe every family deserves answers, support, and a caring partner in their health journey. So grab a cup of coffee, get comfortable, and let's tackle this topic together today. This podcast is for educational purposes only and is not a substitute for medical advice. Please consult your child's healthcare provider for individualized care. Welcome back to the EndoKids podcast. I'm Dr. Rinku Mehra, your host, and I am super excited today to have Dr. Sarah Stombaugh on the podcast with me today. Today's conversation is an important one. Parents are being flooded with information about weight loss medications, often without context, nuance, or medical guidance. And that's why I'm excited to welcome Dr. Stombaugh. She's a board-certified obesity medicine physician who focuses on the biology of weight, not blame, not shame, and she's also the host of the podcast Conquer Your Weight, where she breaks down metabolism, medications, and long-term health in a practical, empowering way. I invited her here because parents deserve clear, science-based answers, especially when these medications are being talked about everywhere, but rarely explained well. So today we're going to talk about what parents actually need to know, what questions to ask, and how to think about these medications. So Dr. Stombaugh, welcome.
Yes, thank you so much. I'm really excited to be here today and talking with your audience. So, such an important conversation, especially in the climate that we're in. Everyone wants to know about these medications, and I think it'll be a great conversation.
Okay, great. Yes, I'm excited to have you here too. So, parents are hearing a lot about these medications, Ozempic, Wegovy, and other medications, mostly from social media. What
Mhm.
do you think is the biggest misconception you see with your patients or even parents having right now?
Yeah, absolutely. Well, I think one of the big shifts that we've started to see, and it's really just we're starting to see this, so we're not all the way there yet, but is how we understand obesity. And previously, and certainly in some places, we still do see obesity as a character flaw. We see it as they're just not trying hard enough, they're not eating well enough, they should just work harder. And we don't see it always for the chronic metabolic disease that it is. And there's been this huge shift really in the last couple of years where, as healthcare providers and starting to come into the community, we're realizing that, okay, obesity is a chronic disease. There are so many factors that affect our weight. It's not just calories in versus calories out, it's everything from our genetics. So we know obesity often runs in families, our epigenetics, so how our genes interact with the environment around us. That can even be, a mother being pregnant, her fetus, when it's inside of her body, that baby is growing and develop. All of that can change what their genes, how they're expressed. We look at the environment that we all live in. We look at our health systems, our behaviors. So there's so many different factors. And we're starting now to really understand obesity as a chronic disease, which then when we start to talk to patients, whether it's children, adolescents, adults, helps us to better understand how we approach the treatment of chronic disease, which is with lifestyle modification and often considering medications when it's appropriate.
Yeah, so, when parents hear the word obesity medication, safety is usually one of the first concerns that they had.
Mhm.
And or they have. And what do you wish parents understood before even deciding whether this is something to consider?
Absolutely. When we think about especially the GLP medications, so the medications you were mentioning, Ozempic and Wegovy, for example, they're in a class of medications, the GLP receptor agonist, and these medications have been around for a while. At this point, the very first FDA-approved medication was Byetta in 2005. So we have 25 years of approved safety data, and the clinical trials certainly started, 5 years or so before that. So we have really good safety data on these medications. And now, especially that we've seen such an uptake in people using them, both across the adolescent patient population and adult patient population, we really see pretty impressive safety data for these medications. So, of course, with anything, you want to be judicious, you want to be aware of what are the potential risk of the medication. But I do think that they are sometimes really overstated when they are talked about in the media or in social media. There's a lot of fear mongering that happens there.
Yeah, so, let's talk about the medication landscape. So, at a high level, what obesity medications are available and what are they actually designed to do in the body?
Absolutely. So, when we think about the pediatric and adolescent patient population specifically, there's really just a handful of medications that are approved in that category. There's an oldie but goodie, a medication called Qsymia, which actually is relatively new in the last 15 years, but it's a combination of two older medications, phentermine and topiramate, that is FDA approved in, I believe, 12 years old and older. And so that's a medication that's used very commonly and has great safety data in the adolescent patient population. The phentermine component of that medication decreases appetite. It's an appetite suppressant. Similarly, Topamax or the topiramate component of that works in the brain to also decrease appetite through a different mechanism. And so that medication, we've got good and long safety data for each of those individual components and now in using them together as well. Very commonly in pediatrics, we may be talking about a different medication called Metformin. This is a medication commonly thought of for the treatment of type 2 diabetes, but it really works at underlying insulin resistance at the liver level. And so it could be helpful for treating some of that underlying insulin resistance that can drive things like diabetes as well as things like obesity. Then, as we talk about some of the newer medications, the GLP receptor agonists that everyone's been talking about, the two that are approved right now in the adolescent patient population are Saxenda. I feel like everybody forgets about Saxenda, but
Mhm.
it's a great option. It's a once a day GLP receptor agonist. No one loves injecting once a day, especially now that the weekly versions are available. And then the weekly version, like Wegovy, for example, Wegovy and Ozempic are the exact same medication. Ozempic for the treatment of diabetes, Wegovy for the treatment of weight reduction. And so Saxenda and Wegovy, these are both medications that are working on the GLP receptor. They work on that receptor, which is involved in areas of the brain that regulate appetite. It's also involved in the gastrointestinal system, regulating gastrointestinal motility. So foods that we eat will stick with us longer. We may feel full for longer after we eat. It regulates the insulin response, or partially is responsible for regulating the insulin response after we eat. So how effectively we utilize our nutrition. And those effects together can have really profound effects on weight. And so those are the medications we're looking at right now. We do anticipate Zepbound to be coming down the pike in the next year, maybe 2 years, but it is approved as Mounjaro. So Mounjaro is a same medication. Mounjaro, Zepbound are both tirzepatide medications. Mounjaro for the treatment of type 2 diabetes, whereas Zepbound is approved for the weight reduction indication. And while Zepbound right now is approved for adults 18 and over, we do know that Mounjaro has a FDA approval for 10 years and older for the diabetes indication. And so that's targeting the GLP receptor. It actually targets a second receptor as well called GIP, and the GIP effect further potentiates the effect of GLP. So it's basically synergistic and a little bit more effective when we compare them to medications like Wegovy.
Yeah, that's a great breakdown of these medications. And I think, parents always often come to me and ask me for the GLPs, actually.
Mhm.
So, we've talked about metformin for a long time in the pediatric population for diabetes and insulin resistance. I don't have a lot of people asking me for phentermine or
Mhm.
Qsymia or Topamax. So when you are, treating some of your adolescent population, patients, what do you look at when you start to think about one of those medications?
Yeah, absolutely. Well, I think we've seen the landscape change too in terms of insurance coverage of these medications. So, medications like metformin, for example, it is almost always covered. There's a rare exception to that, but it's a very affordable medication. It's on the Walmart $4 drug list. And so, that's a really nice option to start because it can be a good fit for some patients, but isn't necessarily going to be terribly expensive. From a Qsymia standpoint, we used to see a lot that Qsymia may be required before other medications were approved. So medications like the Saxenda or Wegovy. And so it may make sense to start there when we're talking about step therapy of, okay, if you want to do a trial of the more potent medications, we need to do the Qsymia first. And so I think there was a time, even 3, 4 years ago, where it may have been a little bit more common, but it never really took off in popularity in the same way that these weekly GLPs have really taken off. We do see if someone has insurance coverage for weight reduction medications. So that's a huge, we could probably talk about that for an hour in and of itself.
Mhm.
But the insurance coverage process for these medications, some insurers are opted into the coverage of weight reduction medications, others are opted out of the coverage of weight reduction medications. But if your insurance is opted in to the treatment of weight reduction, and you have coverage for Wegovy, you have coverage for Saxenda, you have coverage for Qsymia, a lot of times we're talking about, well, let's use a medication that we know is a little bit more effective. That's often very well tolerated. And because there's been so much conversation around those medications, as you're saying, people are coming in, they're asking about those. There's a little bit more trust, I think, just in knowing, oh, my I take it, maybe my neighbor takes it, my
Mhm.
cousin takes it,
Mhm.
all these people I hear on social media take it. And so I think sometimes there's a trust and a confidence with the medication. And so, all things being created equal, I think starting with the GLPs makes a lot of sense, assuming there is insurance coverage.
Yeah, I'm glad you said that. I also wanted to talk a little bit to you, especially about the oral Wegovy, since it's
Mhm,
out. And I know now we're not using it for the pediatric population, but in your adult population, are you
mhm.
using the oral Wegovy? And what can you tell us about it?
Yeah, absolutely. So oral Wegovy is brand new. It was FDA approved in January of 2026. And so I do have a handful of patients for whom I've written the prescription. When we compare it to the injectable Wegovy, the data is really pretty similar. On average, the weight reduction over a year is about 16%, so similar to the 15.6% that we see on the Wegovy injection. When you compare the side effect profiles, they're really similar, seeing things like nausea, constipation coming up as some of the most common side effects. So, from that standpoint, really pretty effective. They are once a day. There are some restrictions around taking the medication that I think will be cumbersome as for some patients. So, they have to be taken first thing in the morning on an empty stomach. So, no food. You have to have a limited amount of liquid. So, you can have less than 4 ounces of water, no other coffee, milk, any other liquids alongside of it, no other foods, no other medications. So, for patients who take other medications, particularly medications like thyroid medications that also need to be taken on an empty stomach,
Mhm.
it could be quite a morning routine all of a sudden where you're trying to separate 30 minutes here and maybe 60 minutes there. So, there's those restrictions. But we are seeing that there's patients who travel. And so, the idea of taking a pill instead of taking an injection is really exciting for them. There's patients who are really opposed to injections, who really wants to be injecting themselves every week if there is a pill option available. So I have a handful of patients that we've just been waiting for the pills to become available, knowing they were coming down the pike. And we were using metformin for those patients previously, and now transitioning them over to Wegovy because they were just not excited about taking the injection. And so they're a really decent option. I was kind of surprised. I guess they just weren't specifically studied in the pediatric
Mhm.
patient population. I do think we'll see the approval for that come down the pike eventually. Um, since we have it for the injection indication, you could probably speak better to that than I could. But a decent option. The insurance coverage for people who have coverage for Wegovy, we're seeing for the prior authorizations when people get an approved prior authorization for Wegovy, it's saying pill or injectable. So it's covering both of those two things in the same prior authorization, which is nice. And then the cash pay option is decent. It's $149 for the first two doses of medication, which is a 1.5 and a 4 milligram dose. Through April. After April, the 4 milligram dose becomes 199, and then the next two doses, the 9 milligram and the 25 milligram dose, are 249 per month, or excuse me, 299 per month. And so those, and that will be the long-term pricing. Although, as we've seen with all of these, the prices of the medications are coming down really significantly. So hopefully we'll still see some movement in terms of the pricing there.
Yeah, I mean, I think it's amazing. When I first started using the medications, the cash pay price was over $1,000, I think, for the
Yes,
prescription. It's
yeah.
amazing how it's come down so
Hmm.
nicely, which is great for our patients.
Hmm.
Well, that's a great high level discussion on these medications. I wanted to shift us a little bit um, and get your opinion on this. So, one question parents ask me all the time is this just appetite suppression, or is it actually treating a medical condition? And you brought that up a little earlier about how this is, chronic disease. But how do you explain that to parents who are asking about these medications for their kids?
Absolutely. Well, I think thinking about the entirety of treatment is so important. So we're not starting someone, maybe in a clinic like yours or mine, where by that point a patient's been working with their primary care physician, whether it's family medicine, pediatrics. We may be starting them day one on a medication, but that's not the first time someone's having a conversation about weight. This is often a child or a patient who has been working on diet, they've been working on exercise, sort of trying to do all of the right things, and then just finding that it is not taking effect in the way that we want it to. And so when we think about what is the role that these medications are playing, we have GLP receptors in many different places in our body. The predominant receptors are in the gastrointestinal system as well as in the brain, but we have receptors in other places in the body as well. And we're finding that the role in terms of reversing, or really supporting, maybe reversing is the wrong word, but treating that underlying metabolic health allows a lot of times all of those changes that someone's been trying to make to finally take effect in the way that they want them to. And even when I say trying to make, that can be even as significant as, trying to eat, high protein and high vegetables, but finding that they're having really significant sugar cravings. A lot of times we think about sugar cravings as an entirely behavioral thing. And while there are certainly behavioral components to some of those routines and habits that we have on foods that we consume, there's a huge part that's actually driven by things like insulin resistance, will often drive sugar cravings. And so when we treat some of the underlying metabolic piece, it allows all of a sudden, you hear people talk about, oh, the food noise goes away. That's because that is that's regulated by the same system here, right? It's not just like all in your head. It's not just like, oh, I have no willpower and I'm just constantly thinking about sugar. There's a piece of this that's really hormonally driven. And so it's so amazing when we can support that underlying piece of it. And so I do think, we're talking about long-term treatment. I think that can be really intimidating, but also recognizing treating, especially in the adolescent patient population and the young adult patient population, we are often changing the trajectory of someone's entire life. When we look at the data of how many patients who have obesity as teenagers go on to have obesity as adults, I wish I could remember the exact statistic, but it's high, like in the order of 90% or so. And these adolescents continue to struggle with obesity, which ends up impacting many different organ systems, everything from our hearts and our brains and our joints. And, the list can go on, the risk of cancer. And so treating and supporting it now, it's not just the risk of the medication, because I think that's a fear is, okay, what's the risk of this medication? What does it mean? Okay, we have 25 years of safety data. That's great. But if we're talking about starting my 15-year-old on it, 25 years only gets them to 40 years old. Does our safety data say what will happen at 60 and at 80 and, for the rest of their lifetime? And when we're thinking about the medication in a vacuum, like what are the risks of the medication, we forget to see what are the risks of chronic obesity. We know that obesity drives things like cardiovascular disease. So heart attacks, strokes. It's a major driver in many cancers, for example. It's a driver in things like dementia. When we look at joints, knees and hips in particular, patients who many years of carrying around excess weight really has a wear and tear on their body. And so the ability to support that early in life, it changes everything, and it's absolutely amazing.
Yeah, that's a great way to look at it, actually, because you're right. I mean, the long-term complications of diabetes in this pediatric population
Mhm.
is, often worse than the side effects of this medication that we're seeing. So,
Yeah.
I started my practice trying to prevent diabetes, and I think this is one of the ways that I've seen that the A1Cs have come down, the cholesterols
Mhm.
have come down, the triglycerides have come down. So, I think that's an important point that you're making. Social media loves to focus on side effects.
Mhm.
And, I wanted to talk to you a little bit about what are the most common ones that you actually see and which
Mhm.
ones are rare, but they tend to get the most attention.
Absolutely. So, when we think of the effect of these medications, many of the side effects that we see are gastrointestinal. And so, certainly, nausea comes up very frequently. Vomiting does come up occasionally, but it's a much less common side effect. We can see either diarrhea or constipation, particularly with medications like Saxenda or Wegovy. It tends to be more on the constipation side, but not always. So, those are the ones that come up most frequently. I think when we look at the side effects, though, in the clinical trials and sometimes what I see when I watch, when I see people on social media, people send me DMs sometimes with the strangest questions and asking me about their side effects. I'm like, go, like, where's your doctor? Go ask your own doctor. I don't even know you. And there are people who are managed maybe by someone who doesn't really understand these medications. But probably less commonly that, more commonly people getting medications online and really not having much support at all. And what we know is that people will have different responsiveness to these medications, both in terms of what is the absorption of these medications. There are patients who absorb them and respond a little bit more effectively compared to others. And so a certain dose may feel more potent in their body. We will often describe these medications as or these patients as super responders. We know that people who have less severe metabolic disease may respond more significantly compared to people who've had long-standing metabolic disease, whether that is elevated blood sugars, whether that's the amount of weight that they have in their body or for how long they've had that weight. And all that to say, when we look at the dosing of the medication and then the titration of it, we can really make sure to support a patient at the dose that is supporting their needs. And so we'll first start at the introductory dose of medication for any of the medications that we're talking about. And then we assess from there, okay, how is it feeling in your body? What side effects are coming up? If you do have them, how are you managing them? How is it in terms of effectiveness? Are we seeing a weight loss in the scale? Are we seeing that at the rate that we expected to? Are you feeling the effects of it in terms of at mealtime? Do you notice that you're eating less? Do you notice that you have desire to eat less often, maybe less cravings for food? So we're taking account of really those three different things. How are side effects managed? What is the effect in terms of the number on the scale? What is the effect in terms of how it feels in your body? And from there, we're making a decision to move up to the next dose if we need additional support, both in the clinical trials as well as how I often see the medication prescribed is like, you start low and you just like every month go up to the next dose. And while that may be appropriate for certain individuals, that's not always the right fit. And
Mhm.
so, meeting someone where they're at, making sure that their side effects are well managed before we consider moving to the next dose makes a really big difference in the severity of side effects. So, when we think about constipation, for example, very severe constipation can turn into things like bowel obstruction. So, that's one of those side effects that we hear about on social media all the time. People are like, you're going to get your bowels are going to be obstructed, it's going to be a medical emergency. And that it happens. I mean, I absolutely believe that it happens, but it is an incredibly rare side effect. I couldn't even quote you the numbers on that side effect. It's an incredibly, incredibly rare side effect. And someone who is having early signs of constipation, when they're checking in regularly with a doctor like you, with a doctor like me, we're noticing, okay, we need to be a little bit more aggressive with laxative medications, with fiber perhaps. What are the things that we're doing in order to keep their bowels moving to reduce the risk of things like bowel obstruction? So I believe most bowel obstructions can be prevented. Of course, there are some that may occur for other reasons as well. Things like gastroparesis or a frozen stomach or a paralyzed stomach, I feel like people are talking about that one all of the time as well. We do know that certain health conditions, like type 2 diabetes, for example, can damage nerves that increase the likelihood of patients having gastroparesis on its own. So, setting these medications aside completely, that can occur for other reasons, including type 2 diabetes. So, especially in a adult patient who's had long-standing and severe untreated type 2 diabetes, they may be at, or they are at an increased risk of something like gastroparesis or that's paralyzed stomach. But for someone who is taking a GLP medication, they are titrating alongside of a doctor. I think it's an incredibly rare side effect. I mean, certainly one we're not seeing very often at all. And so those are the ones I feel like I hear most commonly. I'm curious, are there others that are coming to mind for you?
Yeah, so I had somebody ask me today about flattening, like mood flattening, um,
Hmm.
with these medications, and then somebody else asked me about blindness with this
Yes,
medication.
absolutely. hmm So it's interesting in post-marketing reports of Ozempic, actually. So same medication as Wegovy, they're both semaglutide products. They did see there were some patients who had had increased risk or increased depression and risk of suicidality. So because of that, we've seen a black box warning go onto all GLP medications saying, hey, this medication could increase the risk of suicidal behavior. What's been really interesting is that they've been reevaluating that recently, and I think there's a good chance we see that label go away across all of the GLP medications over the next couple of months, even. So, by the time someone's listening to this, it could be outdated information, even. But all of that to say, these are medications, the GLP medications especially, that are crossing into the brain. And so they do have the ability to impact things like mood. We think about hunger, we think about the way that GLP drives the hunger pathway. A lot of times our hunger is both psychological and physiological, and that's normal. If your stomach is rumbling and you're like, okay, I'm hungry, you feel physiological hunger, and then you go and turn to the refrigerator, you open the refrigerator door and you say, what sounds good? You've now tipped over into psychological hunger. And so it's normal for those two things to be partnered together when we're eating. And GLP is affecting both of those two pathways. So, a lot of times when we see that psychological hunger being driven down, there can be some apathy that comes up, particularly around eating. I have a lot of patients who are like the primary caregiver in their family, a lot of mothers who are like, oh, I have to cook dinner for my family. And like, the idea of like thinking about food, like there's some apathy around food
Mm.
preparation, even because they just don't have that same desire. Like meal prep does not appeal to them in the way that it may have in the past, or maybe it didn't in the past, but it certainly doesn't now either. So there's that psychological piece that comes with it, as well as the effect that we get from eating certain foods. That we, having sugary foods, having foods that are highly processed, high in flour, those really drive a dopamine response after we eat. And so there's a lack of that then that's happening if you're not consuming those foods. And there are people who describe then just some apathy on this medication. So it absolutely can come up. Generally, I see the opposite. A lot of times people find such a freedom around not fighting that food noise all of the time that their mood is actually quite a bit better. And so I would say in my practice, the apathy around eating specifically still does come up at times, and we're talking about that. But apathy in general, and that sort of flatness that you're describing is pretty rare. The good news too is something like that is reversible, and so it's something like, hey, the risk of that is low, and if it comes up, we could always start a different medication. We could go to a lower dose of the medication. It's not one that I would be particularly concerned about, but of course, one people will ask about, as well as then the risk of blindness. So this has been I think talked about quite a bit. So there's two different eye problems that can come up. One is a temporary worsening of diabetic retinopathy. This is most common in people who have long-standing type 2 diabetes and have a growth of the blood vessels of their eyes, basically. Certainly less common in the adolescent patient population, but can come up there. And we do know that rapid improvement in blood sugar control for any reason can temporarily worsen diabetic retinopathy. So that is a known risk. So all the more reason for patients with type 2 diabetes to be routinely screened for the presence of retinopathy by an ophthalmologist. And then there's a separate risk of um, NAION, but a non-arteritic ischemic optic neuritis. I think I'm think I'm doing that analogy or that acronym correctly there. And so when we think about that, this is a basically an inflammation and a blockage of arteries leading to just one of the eyes. It could be either, rarely to be both, but can cause a permanent blindness in the eyes. The risk of this is it's unknown exactly why this happens. It's thought that other factors may contribute, things like elevated cholesterol, for example, especially chronically elevated cholesterol. Other inflammatory factors may drive it. The risk of that is incredibly low. It does happen. I wish I could tell you an exact number. We'll have to find, do you know it off the top of your head,
I
the exact
don't.
number of
Yeah,
it?
I don't know the exact number,
Um,
but I know it's pretty rare.
yeah. I would say on the order of like 1 in a million. I mean,
Yeah.
it's no. Don't, if anyone's listening, don't
Yeah.
quote me on that number,
Yeah.
but it's an incredibly low risk. The risk of worsening of diabetic retinopathy, though, is a real and known risk, which is preventable and at least reversible as well. And so that one, I think sometimes those two get bled into one another, and they're very distinctly different conditions.
Yeah, and I think in the pediatric population, I think those are both pretty rare
Mhm.
for the reasons that you mentioned. I mean, they don't usually have the longstanding type 2 diabetes. In fact, we're trying to
Right.
prevent diabetes. And I haven't heard of, any pediatric patients, but that's not to say it can't happen. But those risks get really blown up in social media. And so I'm glad
Mhm.
you have emphasized that these are all pretty rare risks that we see
Yeah.
in
Well,
patients.
and as I said before, it's that risk too of the untreated disease. And that's the piece that I think, if we're imagining taking these in patients who have just zero risk and they're, like it's a very different situation compared to we know the chronic risk of living with obesity can be significant.
Yeah, and that's a great point. I think that's a great takeaway also from this podcast. But um, you know, this is such great information. I wanted to ask you, in your practice, what do you think success really looks like for patients? So, is it a number on a scale? Is it how they're feeling overall? Is it improved cholesterol or reduction of the A1C? What do you think success looks like for your patients?
Yeah, I think it can look like a lot of different things. I think sometimes my patients will come in with a very specific number on the scale goal. And so, they have a goal weight, and a lot of times they're working towards that. But a lot of times we're celebrating other parts, other wins throughout the journey. And so the number on the scale is very easy to track because it is numerical. But when we think about some of the non-scale victories, those are just life-changing for people. And it's amazing to see everything from changing clothing sizes, finding you're fitting into an outfit that you used to love, finding that you're fitting into a size that maybe you can't remember the last time you wore that size, feeling that your body fits differently in space. And so you sit down on a chair, you're not worried about breaking it. You sit down in an airplane seat, you don't have to ask for a seatbelt extender. I have a lot of patients who, I live in Virginia now. I guess we both do, but in central Virginia,
Mhm.
I'm in Charlottesville, and it is horse country here. And one unexpected non-scale victory that I see all of the time, I have many patients who have given me this victory, is that they go horseback riding again. There's weight limits in terms of being able to get on the back of a horse. And so losing weight and finding that they're able to start horseback riding again. And so it's those non-scale victories that I think end up adding up in a really meaningful way, such that, we're celebrating the changes in cholesterol or A1C, we're celebrating the number on the scale, but it's the being able to, run faster, fit in a space differently, participate in activity that they haven't done. Sometimes it's things like crossing your legs, they haven't been able to sit,
Mhm.
cross-legged, or, just things that we don't always think about strike us in really significant ways when they come up. So I do always like to spend a portion of my visit focusing on wins that have happened, especially those non-scale victories, because those are the ones that tend to be the most powerful.
That's great. I mean, that those are all great success stories. I didn't know that there were limits on horseback riding, but that makes sense.
Yeah,
Absolutely.
right.
Yeah.
It's I know it's not something that had crossed my mind either. I'm not into the equestrian sports, but
Yeah.
it's very common in in Central Virginia.
Um, that's great information. So, the other question I have for you is this is a question that I get from parents also is what happens when the medication is stopped? I mean, that's a big fear for families.
Mhm.
So,
Absolutely.
one, do we need to be on this forever? But if we don't want to be on it forever, what happens when this medicine is stopped?
Absolutely. And that is emerging data. We do have some, I'll say, short-term, intermediate length trials on the order of about a year and a half or so, where they look at patients who have started medications, whether we're talking about Zepbound, whether we're talking about Wegovy, and then when they have stopped the medication or continued. And one of the trials, they half the group stopped and half the group continued. And when we look at patients who've discontinued the medication, on average, patients regain some or even most of the weight back, but not all of it. I think the thing that's really interesting, though, is if you look at the waterfall distribution. So you see, okay, the average person regains, let's say, 10 to 14% of their total body weight, and that'll depend on which weight medication we're talking about. You, the patient, in front of me, is not a average person. They are a very specific individual. So if we look at the waterfall distribution, we took every single person that contributed to the average. We see this really wide distribution of people who regained all of their weight plus more to people who were able to maintain their weight or even continue to lose weight. And there's a lot of factors that drive that. One of the things in the clinical trials, most of the clinical trials we see, the nutrition intervention is, hey, try to eat in a 500 calorie per day deficit. The exercise recommendation is get 150 minutes of exercise per week. And while those are, fine recommendations, that was the entirety of the lifestyle intervention
Mhm.
counseling in most of the trials. And so when someone is given the medication and then really just left to their own, the results look very different, both short term as well as what that looks like long term. And so I always tell people, we want to at least be open to the idea of taking it long term. This is designed as a long term medication, but it's really important that the patient knows, whether it's the parent, whether it's the patient, like they are the boss of their body. They get to decide if they're taking a medication, for how long they take a medication. And if someone wants to stop a medication, I will be 100% supportive of that. It is safe to stop the GLP medications abruptly. You don't have to wean off of them. So if you had a severe side effect, if someone became pregnant on a medication, something like that, we can absolutely stop them abruptly. That's totally fine. But if someone is deciding that they'd like to stop, just to sort of see how I do off of the medication, we may talk about what does it look like to wean off of the medication. So perhaps spacing out dosing a little bit, taking a step back just to the next lower dose in the titration scale, and looking to see how is your body feeling, what is response, and matching them with where they're at. Because a lot of people may do well at a lower dose of medication. I find that very frequently, especially with my adult patients, that they may do well on like a Zepbound 5, for example, which is the second of the 6 doses of Zepbound. I have a lot of patients who may take an intermediate dose of Wegovy long term. So I do find that patients may do well at a lower dose, and they find that they really love the way the medication feels in their body. And I think that's the piece too. When you're starting out, you're thinking about the risk, you're thinking about the benefits in terms of number on the scale or A1C or that type of thing. But until they experience taking the medication, I think a lot of people are surprised by the mental freedom that they find around food. In adult patients, also around alcohol, we find coming up where patients have a lot less desire and cravings for that. And so that decrease of food noise, though, is so empowering that once people are taking it, they realize, hey, I actually like the idea of taking this long term is actually pretty desirable. And I do want to continue it long term.
I love that you said that. Yeah. So, my final few questions for you, and this has been so educational for me also, even though I provide a lot of these weight loss medications, but I think you've provided so much clear information for our patients and for our listeners. But, if a parent is curious but unsure, what's the first step that they should take?
Mhm. Absolutely. So I do think that seeking out, starting with the physician that you have. So whether that's your pediatrician, whether your family medicine physician, when your child is in for their well visit, get an idea of what is their weight, what is their BMI. In children, we're often talking about BMI percentiles. So where does your child compare to the average child of their gender and of their age? Where they fall in that spectrum. Are they a candidate for these medications. So typically, we're thinking about people who have a BMI of the 95th percentile or higher are a candidate for these medications. I think one of the challenges that we run into right now is that there is still such an obesity bias in our medical community, including physicians, including primary care physicians. And so knowing that, like, if my child meets criteria, not that I have to move forward with these medications, but if, asking a pediatrician, asking a family medicine physician, hey, would my child be a good fit for this? Even if you're not the person to prescribe it for me, is there someone else in the community that you trust? Is there a pediatric endocrinologist? Is there a pediatric obesity medicine physician? Is there someone in the community who I could meet with and get, have some conversations around this? And those conversations can be just that. Like, they can be educational. There's no commitment. If someone comes in for a visit with you, they're not walking away guaranteed with a
Mhm.
prescription, right? You're giving your opinion, they're giving their concerns, and you're making a shared decision together about what makes the most sense for the patient in front of you. But advocating for yourself, advocating for your child, asking to see the people who can support your child, I think is so, so important, because we're often seeing people who may be really great candidates for this medication turned away and not given access to it. So asking for, hey, who are the people in my community? Who are the physicians who could really support me with this? And I do think, especially in the patient population for pediatrics, that having a really experienced physician with pediatrics will be important here.
Yeah, I mean, I think that's such an important message, and I think that's an important message that you said. I mean, there is a lot of weight bias, and I don't know if some of these patients are being given the opportunity to even try some of these medications. So I think
Mhm.
that's an important message that you just mentioned. Um, if you wanted to give a general pediatrician just one message about childhood obesity and these medications, what would that be?
Mhm. Absolutely. I think an openness to them, whether that is either for yourself in prescribing them or just being very clear with who are the other physicians in your community that you can have a relationship with. And so who are you referring to? What does their wait time look like? How can you help support their patients if they are interested in this? And so making sure that patients have a trustworthy source. I think we are in such a bizarre time with these medications that you can get, especially some of the compounded medications, so generic semaglutide, generic tirzepatide. We say generic, but sort of knockoff versions of these medications that may or may not be safe depending on where they're made. You can get those just about anywhere. And I think we're finding ourselves in a place where a lot of patients are really desperate. They're really interested. And even for the adolescent patient population, parents may be seeking this on their own, or adolescents may be seeking this on their own. And so be either open to prescribing or know who can prescribe so that you can keep your patients in a safe and supportive environment.
Yeah, that's a great message. Dr. Stombaugh, I want to thank you so much for this conversation. I think you have enlightened our listeners and given us such detail in such a, with such clarity. I do think it's important. What's so important for parents to hear is that this is not about quick fixes. It's not about blame or willpower. It's about really understanding biology and getting the right medical guidance and medical advice, and knowing that there are thoughtful, evidence-based options, evidence-based physicians that are available to help when lifestyle changes alone are not enough. For parents listening, if today's episode raised questions or curiosity, the takeaway isn't to rush into medications, it's to have a better, more informed conversation with your child's pediatrician or specialist. And Dr. Stoma, can you tell us a little bit more about where patients can find you if they are interested in working with you? Because I think you're very approachable and you offer very practical guidance for your patients.
Yes, absolutely. Well, I am located in Central Virginia in Charlottesville. I do see patients in person there in Charlottesville, as well as throughout the state of Virginia, Illinois, and Tennessee. So, if patients are interested in telemedicine, I can see them in any of those states. I do love to work with particularly adult patients, but I'm a family medicine physician by training. So, I do see some adolescent patients in my practice right now. It's a little bit harder just due to my current work environment and just the hours that I'm seeing patients, but I love being able to support that patient population. So anyone who's in Central Virginia, I would love to help you. A big thing, as you mentioned at the beginning, I do have a podcast, and I've been really working over the last couple of years to have some great free online resources available for people. Because social media, especially around these medications, is such a noisy space right now. And so I really want to be a voice of reason, whether it's the medications, whether it's thinking about the psychology of eating, the relationship we have with our food and with our bodies. Those pieces are really important to me. And so you can find my podcast at Conquer Your Weight. I also recently put the podcast also on YouTube. And so I would absolutely appreciate anyone who's listening, if they could find me on YouTube at Conquer Your Weight to subscribe and listen over there, it would mean so much because that is just starting to grow, and I'm excited to share with people over in that direction. So thank you for having me. I really enjoyed being able to talk about these GLP medications and what people should be asking about. So this has been such a fun conversation.
Yeah, thank you again for being here and for helping bring clarity to the topic that so many families are navigating quietly. I really appreciate you taking the time. So thank you so much.
Yes, absolutely.
Thank you so much for joining us on the EndoKids podcast. We hope you're leaving with a little more knowledge and a lot more confidence. If you have questions, stories, or topics you'd love us to cover, please send them our way. We love hearing from you. And don't forget to check out our website, www.endokidsconcierge.com, for free resources, guides, and more ways to connect. You're not alone on this journey. We're here to support you and your family every step of the way. If you enjoyed this episode, don't forget to subscribe to our podcast so you never miss an update.